Assalamu alaikum. My name is Muhammad Awais, and I am an assistant professor in Akhtar Said Medical College and Akhtar Said Hospital. Our today's topic is upper respiratory tract infections, and in which we will discuss tonsillitis, croup, and acute epiglottitis one by one. So, first is the tonsillitis. As you already know, tonsillitis is a form of pharyngitis, and in which there is an intense inflammation of the tonsils, often with a purulent exudate. There are common pathogens which are bacteria and viruses, and example in bacteria is sorry, my mobile is ringing. So example in bacteria is group A beta hemolytic streptococci, and example in viruses is Epstein-Barr virus, which causes infectious mononucleosis. It is the name of the disease, and these are the examples of bacteria and virus, but there are other many bacteria and viruses which can cause tonsillitis and pharyngitis. Coming to the clinical features, although the surface exudates seen in infectious mononucleosis are reported to be more membranous in appearance compared to the bacterial tonsillitis, but in reality, in fairness, it is not possible to distinguish clinically between viral and bacterial causes. So no doctor sitting in an OPD would check the throat of the child, and just by seeing the throat and examining the throat can tell you that yes, this is bacterial or viral. So there are some clinical parameters. However, as per rule, as you already know, the bacterial infections are more intense. For example, there are marked constitutional disturbances such as headache and apathy and abdominal pain due to tonsillitis, which is called mesenteric adenitis, and some time you get white tonsillar exudate on throat examination, and also on examination you could find cervical lymphadenopathy, and it is more common in the bacterial infection, but it is not hard and fast rule. So in this diagram, as you could see, the redness, the erythema of the throat, the fascial pillars, uvula, the posterior pharyngeal wall, the tonsils are inflamed and a little bit bigger in size as well. And you could also see the white exudates on the tonsils. However, you cannot always see these white exudates. Sometimes there could be only inflammation of the throat. So after a simple case of pharyngitis or tonsillitis in which you suspect, for example, a bacterial infection, you would definitely need antibiotics for your patients. And the first choice of antibiotic is often penicillin, or if the patient is allergic to penicillin, you would go for the erythromycin. And these are the most commonly prescribed medications in the bacterial infections, but one should keep in mind that most of the pharyngitis and tonsillitis are through the viruses. Only a third, one-third cases are due to the bacteria. The antibiotics definitely may hasten the recovery from the streptococcal infection in order to eradicate the organism. To prevent rheumatic fever, which is a complication of group A beta hemolytic streptococci, 10 days of treatment of antibiotic is required. In severe cases, children may require hospital admission for intravenous fluid administration, and the pain in the throat, they need analgesia if they are unable to swallow solids or liquids. So most of the cases you would send them back home, but as I already said there would be few cases who would not be able to take orally well, especially if the child is dehydrated, coming in OPD with upper respiratory infections. You may need to keep the child in the hospital for IV hydration. In case of um, infectious mononucleosis, which is a viral infection, if somebody gives amoxicillin, that can cause widespread maculopapular rash on the body. And sometimes this kind of MCQ you can get in the exam as well. And the question would ask you what could be the best diagnosis after giving amoxicillin. The child developed maculopapular rash. So the diagnosis, the answer would be infectious mononucleosis. So this is bit about the acute. This was a bit about the acute tonsillitis. Now we would move towards the second upper respiratory tract infection, which is croup, and it is quite common in certain seasons in Pakistan as well. So with the laryngotracheobronchitis, usually called croup, there is mucosal inflammation and increased secretions affecting the airway. But it is the edema of the subglottic area that is potentially dangerous in young children because it may result in critical narrowing of the trachea. This is and this is an emergency, not necessarily present in all the groups, but in severe group, this could be the life-threatening emergency. Viral group accounts for over 95% of laryngotracheal infections. So the mainly cause is viral, and the most notorious organism for that is parainfluenza virus, and the most common one. And but other viruses such as human metapneumovirus, respiratory syncytial virus, and influenza can produce a similar clinical picture. Croup occurs from 6 months to 6 years of age. The peak incidence is in the second year of life, and the weather most common is the autumn. What are the clinical features of croup? Nobody comes with the diagnosis on the forehead that the child is croup. So you may get the child with the problems. The mother may come in the OPD and would describe that the child is having a low-grade fever on the coryza and has having hoarse voice. His voice has been changed for 1 to 2 days, and sometimes the child coughs in the OPD, and if you hear the cough, that will be typical barking cough, and along with a stridor. And stridor is an inspiratory sound produced due to the narrowing of the upper airway. Sometimes you can hear it from the naked ears, like without the use of stethoscope, but most of the time you need a stethoscope and a silent room to hear or auscultate for stridor. And symptoms are usually worse in the night. This is the radiographic presentation of a child with a croup. You could see the narrowing of the airway, and in the subglottic area it is called the steeple sign, and the lateral view is showed as well. So management: when the upper airway obstruction is mild, the stridor in the chest procession disappear when the child is at rest, or sometimes the stridor may disappear when it is severe as well. So in the case of complete obstruction of the airway, so the disappearance of stridor is not only a relieving factor for the doctor that the child is getting fine, but sometimes it can be disastrous. Sometimes acute obstruction of airway may occur as well, and the stridor may disappear. The child can usually be managed at home. Yes, definitely the parents need to be to observe the child closely for the signs of increasing severity. The decision to manage the child at home or in the hospitals is influenced not only by the severity of illness but also by the time of day. Like if it is night and the parents are coming from remote area and from some village, and they have not easy access to the hospital, so keep the child in inside the hospital, and the child is aged less than 12 months of age, and if the parents are anxious about the health of the child, so you should also admit these kind of children as well. So management is inhalation of warm moist air, which is widely used but is of unproven benefit. The mainstay of treatment is the nebulization with the steroids, especially budesonide, to reduce the severity and duration of the croup. And sometime we need to give oral prednisolone, and sometime injectable dexamethasone as well. And in case of dexamethasone, a stat shot of 0.5 milligram per kg would be sufficient. For oral prednisolone, you may continue for 3 days in the morning, and the dose you can give from 1 milligram to 2 milligram per kg. Maximum dose is 40 milligram. In severe upper airways obstruction, nebulized epinephrine, which is called racemic epinephrine with oxygen by face mask, provides transient improvement. But one of the problems with the racemic epinephrine is that it could cause rebound congestion. So you should be aware of the rebound symptoms of the congestion, and an anesthetist and intensivist should be involved in the care as well. Only a few children with croup require tracheal intubation because of steroid therapy. Some children have a pattern of recurrent croup, and that may be related to the atopy, which is a condition of familial condition in the family of people, like eczema or asthma runs in the family. So the people having eczema, allergies, and allergies like dust allergy, hay fever, asthma, and eczema, these come under the umbrella of atopy, and these things run in the family. So next is acute epiglotitis. This is a severe condition, and is a life-threatening emergency due to the high risk of respiratory obstruction. It is caused by Haemophilus influenzae type B, so it is a bacteria. In the UK and in many other countries, like in Pakistan, the introduction of universal Hib immunization in infancy has led to more than 99% reduction in the incidence of epiglotitis and other invasive Haemophilus influenzae type B infections. There is an intense swelling of the epiglottitis and surrounding tissues associated with septicemia. Epiglottitis is most common in children aged 1 to 6 years but affects all age groups. The onset of epiglottitis is often very acute with high-grade fever. This is in contrast to the group in which there is low-grade fever, toxic-looking child. This is also in contrast to croup, and the child would be happy in most of the cases of croup, but in severe croup definitely toxic looking, and intensely painful throat that prevents the child from speaking or swallowing, and saliva would be drooling out from the chin or from the sideways of the mouth due to the obstruction. Soft inspiratory stridor and rapidly increasing respiratory difficulty may occur, and the child would be in the sitting immobile position, upright, and with an open mouth to optimize the airways. In contrast to viral croup, cough is minimal or absent, and attempts to lie the child or examine the throat with a spatula or perform a lateral chest X-ray must not be undertaken, as they can precipitate total airway obstruction and death. So we should be very careful if we are anticipating the diagnosis of acute epiglottitis. We should keep the child, the patient, at ease, at comfort, and we should not even try to put an IV line, and because these procedures can aggravate the anxiety of the patient, and that can lead to the total airway obstruction and death. So minimal handling. So this is the lateral radiograph of the soft tissue showing the edema of the epiglottis, and it is giving us a thumbprint sign, and this is a radiological sign. If the diagnosis of epiglottitis is suspected, urgent hospital admission, treatment is required, and should be a teamwork between anesthetist and pediatrician and ENT surgeon, and treatment should be initiated without any delay. The child should be transferred directly to the intensive care unit or in an anesthetic room, and must be accompanied by senior medical staff in case respiratory obstruction occurs. Child should be intubated under controlled conditions with the general anesthetic. Really, this is impossible, and urgent tracheostomy is life-saving, as the edema is a factor which can cause problem in intubating the patient, and in this situation really we need the tracheostomy. Only after the airway is secured we should take blood and for culture sensitivity, and IV antibiotics like cefuroxime started. The tracheal tube can usually be removed after 24 hours, and antibiotics should be given for 3 to 5 days. With appropriate treatment, most children recover completely within 2 to 3 days. As with other serious Haemophilus influenzae infections, sorry, excuse me, prophylaxis with rifampicin is offered to close household contacts. So take home message, minutes count in acute epiglottitis. Should be very much careful. It's a life-threatening illness. Thanks very much. If you need any questions, you can definitely contact me through my WhatsApp or through my email or through my Facebook account. Some are already in contact with me, and if you don't know my contact number or WhatsApp number, you can contact with the admin and they can hand over you to the same. Thanks very much. Thank you.